Yeah.
1 second, sir. Hold on.
Okay.
Good evening, one and all. Welcome all to Vayomanasa Sanjeevani's webinar series. Today's topic for the day is interplay of medical comorbidities with mental health issues. To talk about this, we have Dr. Thomas Gregory Isaac. I welcome you, sir, for today's session. And our moderator for the day is Miss Lima Paul. I welcome Lima also for today's session. Introducing Lima, she is doing her fellowship in psychosocial care for elderly at the Geriatric department. With that, I would like to welcome all our Zoom and YouTube participants for the day. Now I request Lima to address our speaker. On to you, Lima. Thank you.
Thank you, Gita. Good evening, everyone. I would very happy to introduce our resource person, Dr. Thomas Isaac, currently working as an associate professor, Center for Brain Research at Indian Institute of Science, Bangalore. He is having PhD in vascular dementia and MD in psychiatry, and also completed DM in geriatric psychiatry from NIMHANS. I welcome Dr. Thomas Isaac to speak about the interplay of medical comorbidities with mental health issues.
So thank you very much. At the outset, I would like to thank the Vayomanasa Sanjeevani team, which has been the important kind of thrust point, as well as an outreach kind of program, which is quite unique in this decade of healthy aging. And I especially give my thanks to Professor P.T. Shivkumar for this opportunity as well. Today, at the outset, I would also like to apologize for the technical difficulties which resulted in some of the delay in the initial aspect. So without much further delay, let's go into the main topic, which is the interplay of medical comorbidities with mental health issues. So this is an important topic because we have to understand that medical issues are not just physical problems. There are also mental health issues. There are social issues. And when all this together interact, especially in a dynamic fashion in elderly, this would give a difficult kind of challenging scenario, which as health professionals we have to address, and as lay people we have to identify so that immediate help can be given. So what is the aspect we can actually learn with this particular case? So I would request everybody to go through this particular case. So he is Mr. S. He is a quite senior person, 76-year-old retired accounts officer from Bangalore. He has history of diabetes mellitus since past 15 years, hypertension since more than 20 years, but he is irregular with medicines. He had history of ischemic heart disease, for which he had underwent angioplasty 5 years back. And because he was not very regular with medicines and worsening of his diabetes and hypertension, he also had to undergo artery bypass last year. His wife passed away 3 years ago, following which he stays alone as both children are abroad. So they have arranged a maid who comes for a household chores and goes away by afternoon. So after that, the patient is relatively lonely. He is alone. And since 3 months, they have noted that he started having reduced sleep, occasional crying spells, irritability, for which the caregiver, actually who is the maid who comes off and on, took him to the local hospital, and he was started on some antidepressant medicine since 2.5 months. So after starting that, about 2 months back, that is about 15 days after starting this medicine, he had developed giddiness and fell down in the bathroom. Then he developed a hip fracture and he needed surgery. So subsequently, when they evaluated him during the surgery, his sodium levels were very low. It is 123. Normally it's more than 135. His HbA1c, which is a marker of his diabetes, is quite high, 9.6 gram per deciliter. And fasting sugars and postprandial sugars are 200 and 350 range. So all this, he was treated. He is currently back home with another paid attendant who is not well trained. I think this is a common scenario, and we would have many friends, relatives, even some of our well-wishers, senior citizens who would have similar issues. So how do we help? So actually this talk is entirely about that. When there is not just one morbidity due to a psychiatric illness, there can be other physical issues as well. So at the outline, I will be looking into the medical comorbidities. As we age, what all are the common medical comorbidities? Then what are the associated mental health disorders and independent mental health disorders? And what is the interaction and how it is complicating the situation? Then we'll look into the patient factors, illness factors, what are the environmental social support system, then understanding the risk factors, and finally how to manage it. So we all know that medical comorbidities are quite common in any elderly. So it's a normal thing. There has been some systematic attempts to understand that in India. So Indian Association of Geriatric Mental Health conducted a survey in 2018, wherein they found that at least 78% of the people had at least one physical comorbidity, like Parkinson's disease, hypertension, heart problem, diabetes, kidney, prostate problem, or cancers. Then LASI was one of the major studies in 2020. It found out that more than 25% of the older adults aged 45 and above had at least one comorbidity like diabetes or hypertension or any of the things which I have told before. And 18%, about 1 in 5 people have multiple problems, more than 3 problems. And around a quarter, that is at least 25% of people more than 60 years of age have multiple problems, either diabetes, hypertension, lipid, cholesterol issues, or they could have visual problems and other comorbidities. So one thing we all know that it is very common. Now, National Mental Health Survey, which was also done after initiative by NIMHANS in 2016, wherein it was identified that older adults had higher prevalence of depressive disorders and any psychiatric morbidity than young adults. So compared to younger adults, the prevalence of depressive disorders are much more. Also, if the particular person is of female gender, lives in the urban area, is unemployed and having lower income, they have more association with common mental disorders compared to their other contemporaries. And older adults had a higher lifetime and current prevalence of depressive disorders as compared to the younger adults. But there was no difference in prevalence of anxiety disorder in different age groups. So compared to anxiety, it was depression which was more common in elderly. And the most prevalent anxiety disorder in older adults was specific phobias. And all common mental disorders in older population were more common in females, those living in urban metros, unemployed, or who were not currently married, and those with lower household income. So this was what was happening. Okay. Am I audible or is there an issue with my audio? Hello.
You are fully audible, doctor.
Okay, sir. Thank you very much.
Thank you.
None at all.
Thank you. Thank you very much. So what are the interactions? So last Vayomanasa Sanjeevani session on Monday, we had actually discussed about diabetes. Okay. So I would just take that particular example to go ahead with my talk. I have tried to simplify it as much as possible. So it is now understood that more than 3/4 of the elderly patients with depression have at least one comorbid physical illness. So if you have depression, it is likely, very much likely, that you will have one associated physical illness also. And similarly, ulta, those with comorbid physical illness had greater severity of depression, of somatization and anxiety. So if you have physical illness, then if you get into depression, the severity will be more. Somatization symptoms will be more. Anxiety will be more. And incidence of depression is 2 to 4 times more in people following an ischemic heart disease or a stroke. You would have heard of people who had got heart attack. They have been in ICU, but they come back, they stay at home for some time. After bypass also, many people would be taking rest for 1 month or 2 months. That time you notice that they are not like before. They have some sad mood. They may be having mild irritability. They may be sad at times. This is not a very uncommon phenomenon. Many people have it. So that is something which we have to understand. and presence of vascular depression. People with hypertension, other vascular risk factors like obesity, metabolic syndrome, all can develop depression as well. And it is now well known that if you have late life depression, you are at an increased risk for developing neurocognitive disorder like dementia. So that is very much important. And I have to add one more thing. COVID has completely tilted the balance. So people who have physical illness or psychological illness, they have become more socially isolated, more withdrawn in the COVID times. Due to the infection also, there are some changes in the body. All this can together worsen the risk for developing dementia and or severity of the depression. So coming to the previous example that I was citing, this was about diabetes and depression and how they are linked to each other. So my first picture shows the downward spiral of depression. So what happens usually? Somebody feels unhappy. So when he feels unhappy, he won't interact with others. He or she will spend more time alone, thinking that, okay, let me be alone, I'll become a little better. But it doesn't happen. When you are alone, you think on the same thoughts again and again, you feel more depressed. And when you feel more depressed, you feel less and less active. And when you become less active, less stimulation, you feel more depressed. So this is a never-ending cycle. Now coming to diabetes. So when you are depressed, it is very likely that you will not venture out of the house much. You will develop unhealthy behaviors also, like binge eating. Somebody who's smoking, started smoking excessively, feeling that that will give some relief. That's the only source of relief for him. So he will start smoking excessively. He will have reduced motivation, so he will not exercise. As a result, he will gain weight, he will become obese. He also will feel no interest in taking medicines, no interactions, and also there could be other physical problems like insulin sensitivity could be affected. There could be worsening of the inflammatory markers, increased cortisol, all this can be. Again, diabetes is something which would require treatment. So if treatment is not there, the blood sugars are going to rise. Then there will be stress of diabetes management. I know many of my elders, in my family only, who are aversive to take insulin. They feel they kind of bargain with the doctor. Sir, would you please give me tablet instead of insulin? Because insulin, they think, is the last modality of treatment. That is not uncommon. And therefore, poor symptom control will happen. Then they will be having difficulty in making dietary changes. Especially many years they are eating one particular diet, they cannot change it. Doctor will tell, please change it. It's difficult for them to do. There could be difficulty in exercising and increased exhaustion. And there can be increased complications of the medical illness. So diabetes and depression are actually kind of sister disorders. We cannot separate one from the other. So there has been one landmark study in India, which is known as the independent study. This was actually not done by psychiatric people. It was done by actually medical doctors in a diabetes clinic in South India. So they had looked at this study, which is known as independent study. It is integrating depression and diabetes treatment. So they did study in two groups of people. So in one group, they gave usual treatment for diabetes. In the other group, they had an extra support of care coordinators who would screen and counsel for depression, which is known as the intervention of the study arm. And the other arm consists of individuals who received only routine care for diabetes. So what did they find out? They found out that compared to 54% of the individuals in the control arm, those who had improvement in their depression scores after counseling, so improvements in metabolic control, sugar, BP, and cholesterol, and they found that 72%, almost 3/4 of the people in that intervention arm, which included counseling and psychological inputs, were able to achieve improvement. So about 18% improvement extra was seen in the intervention arm because of the collaborative care. So this underlines the importance of giving not just medications for diabetes, but also psychological inputs, which is very much required. And I am sure all of you would also agree to it. There was a similar study for DIL study, which is the depression in late life study in Goa. So they had done some small interventions. One intervention is the volunteer would be advised by the caregiver or psychological social worker to go. Psychosocial worker will tell to actually look after your comorbidities like diabetes and hypertension, and they will kind of go and address it. And mind you that these people had depression, and they noted that those with these simple interventions, you do not require a lot of medicines, but they showed significant improvement. So that is the importance. So with all this, the current recommendation is that in any diabetes clinic, you have to screen all patients for depression. Because I told you these are sister disorders. If you have diabetes, you have increased chance for depression. And if you have depression, you have increased chance to develop diabetes. Therefore, you have to screen all patients for depression. And if there is no depression, you don't have to worry, follow the usual care, and also psychologically support them so that they don't get into depression. Now, if there is depression present, you classify it as mild, moderate, or severe. If it is very severe, they may require a mental health professional or psychiatrist help. If it is mild or moderate, you need to provide only motivation, social support, continue the follow-up, and give counseling. So this can be done. So this was the important aspect I was discussing till now. That is diabetes and depression in diabetes. The prevalence rates in depression could be up to 2 to 3 times higher in patients with type 1 diabetes and twice as high in people with type 2 diabetes compared with general population. So if you have diabetes, there is an increased risk for you for developing depression. So you have to be careful. I'm not frightening people with diabetes here, but rather I'm telling you that actually with proper lifestyle changes, if you improve your diabetes, your risk for developing depression is less. And similarly, if you are depressed, if you kind of control that or treat it properly, your chance for reducing or your blood sugar is much high. Anxiety appears in 40% of patients with type 1 or type 2 diabetes. The presence of depression and anxiety, excuse me, in diabetic patients worsens the prognosis of diabetes, increases the non-compliance to treatment, and decreases the quality of life and increases mortality. Okay. On the other hand, depression may increase the risk for developing type 2 diabetes with 60%. That's important. And it seems that there is a bidirectional association. So this is the bidirectional association which I was actually talking about. So diabetes can lead to depression, and depression can be a risk factor and worsen diabetes. So patient factors are there. Now coming to patient factors, illness factors and environment factors. Patient factors are there which can predispose to diabetes. So somebody has asked me in the chat, what is MI? MI is myocardial infarction, or the colloquial term is heart attack. C-way cerebrovascular accident, the colloquial term is stroke. So just I'm clarifying that for understanding. So patient factors are elderly age. The more elder you are, the more risk for developing diabetes and depression. If you are a frail person, there is an increased risk. Life events, many life events like stressors, like your family, there could be other life events like you are getting retired, your children are getting married and leaving. And in such situation also, there's increased chance for developing depression. You should also notice that in some life events like bereavement, death of spouse, sometimes the medications are also missed. So the diabetes can also be uncontrolled. So these are some things which are also quite important. There could be other comorbidities like hypertension, cholesterol issues, which are also important. Also, there's a role of stigma. Stigma, I think everybody would have known, is some kind of negative feeling that you have or some prejudice you have with respect to people with psychological illness. So that can also cause significant issues. And family acceptance and role. Now, when you are elderly, the family acceptance is how much towards the particular person. And his role as the main breadwinner is also not there. So these are important challenges. Plus he is having diabetes. Who is going to support his treatment? All these issues are there. So that has to be understood. Some myths and misconceptions. As you age, you have the concept of grihastha and sannyasa and vanaprastha and all as part of the Indian culture. And when you are becoming elderly, now your lifespan is also increasing. You are supposed to stay at home. You are not supposed to go out. You are not supposed to talk excessively. You are not supposed to interact. Some people will have these misconceptions. And most important, importance of treatment. As you get older and older, I have seen many people denying treatment. They'll tell that, no, I don't require any new medicines. This will be enough. I will take the old medicines. Some people will tell, no, I will not at all take any other form of allopathic medicines. I will take only indigenous medicine, or I will take some other forms of medicine. It is not against the systems of medicine, but some medicines which has helped you, it is very important that you should consult before taking a call of your own. So these are some of the patient-related factors which can actually play an interplay when you have a psychological illness. So this is an important aspect. Now coming to illness-related and treatment factors, severity. It is very severe. Then you know that people will take you to the hospital. But sometimes what happens, you will be depressed, but it is not very severe. It is very borderline. So you also won't feel like going to take the treatment. The family members also feel, okay, it is part of his old age and her old age, some age, some concern, and that severity can also affect. Treatment related aspects, very much neglected, but very much important. Whenever a patient, an elderly patient comes to a doctor, we ask what all medicines you are taking. They'll take Telma tablet for hypertension. I take Dionyl tablet or glibenclamide tablet for diabetes. I take atorvastatin or rosuvastatin for cholesterol. But they will forget to tell there are 2-3 other small medicines in Ayurveda or Natya Aushadhi or some other homeo medicines which they are also taking. So that also is also something which they are taking. They will feel that if I tell that, the doctor will shout at me. He will tell that no, these medicines are not required. But actually the truth is you have to tell what all medicines you are taking. The doctor should not shout at you. He should actually look at the content of that medicine and help in understanding whether that is required or not required. And something known as polypharmacy. Most of the elderly, if you ask to show the list of medicines, they will show a list of at least 5 or more medicines. A list of medicines which are by 8 o'clock or 9 o'clock they are supposed to take. Some medicines in morning with before food, some after food. The entire list will be there. Some problem is that you consult one doctor, then you consult another doctor. He will also give his own list of medicines. As a result, we will have duplication of medicines also. We have seen patients who have the same medicines written by 2 different types of people, doctors, and they are continuing to take double dose because they are following both the prescriptions quite faithfully. So that also can happen. Sometimes it also happens that some of the medicines are missed in one doctor and is written by the other doctor. So if you follow the first prescription, you will have lesser number of medicines. So that is also another challenge. So the most important solution is whenever you go to a doctor, if you have a general physician or a family doctor with you, you have to make a list of all the medicines in one particular prescription. That has to be kept with you. In case of emergency or in case of another consultation, that list of full medicines, which can also include Ayurvedic, Siddha, homeopathy, Unani medicines also. If you have difficulty in writing their names, at least snapshots of that in the mobile phone is important. So that when in case of emergency you're consulting any other general physician, you show that. And once they see that, they'll be able to recommend the needful treatment. Locomotor disability is also an important factor. Many a times people don't take illness because they cannot travel till that. Even if they go to the hospital, they have difficulty in accessing the stairs or getting the lift, or they require somebody to be with them. I'm sure this has been a common phenomenon. So many a times we would like to go to hospital regularly, but there is nobody to take us. There is difficulty because we alone cannot go. In a city like Bangalore, I don't know, it's very difficult. Some people are very tech savvy, they can easily book a Ola or Uber cab. But for some people, it's a disability. They have to rely on local friends or neighbors or their children. Only when the children are free, they can be taken. So these kind of logistical issues are also there. There are iatrogenic causes. See, all the medicines which you are taking are also chemicals. They are produced by not just in the body, they are produced in other factories and laboratories. And these have their own side effects as well. So unless there is an indicated need for medicines, too much medicines can actually give more side effect, and suboptimal dose of many medicines can also give side effect. So if you have one medicine, you have to discuss with the doctor. Doctor, what would be the side effect if I take this medicine? That is the adverse effect. Many of the medicines, if you take, you will get gastritis, you might get some kind of nausea. Some people have vomiting feeling. So you should discuss with the doctor so that you are warned. And it is not that you will have side effects. Very few people only develop side effects. So this is something which you have to understand. Also, drug interactions. Many are elderly. There is a possibility if you have diabetes, hypertension, bronchial asthma, or if you have dyslipidemia, you will be taking many medicines. These medicines can also interact between themselves and can worsen the side effects. So these are something which you have to discuss with your family doctor before actually taking that. So that is very much important. And it is also to understand that drug interaction should not deter you from taking medicines, because medicines are very much important. So the doctor will weigh the risk and the benefit, and if the benefits outweigh the risk, then the medicine should be taken. Now, there are some environment and social factors which have an interplay. So if one of the most important aspects are 3 A's. First of all, the medications or the treatment should be accessible. It should be affordable and it should be available. So accessibility is very much important. If you have to go there and you have to get that medicine or treatment, it's very much important. Another important is affordability. If you are drawing a pension of 30,000, but your monthly medication list is coming to about 60,000, how are you able to afford medicines? Some of the vitamin pills per tablet will cost more than 20 rupees. Is it worth taking it? So these are some discussions you need to have with the doctor. Some of the insurance related issues can also come. So you have to kind of discuss this beforehand about affordability. Also discuss with the doctor whether vitamins and other kind of supplements are required long term. Some of these have a definite time, like 3 months or 6 months. After that, you need not maybe take it. So these kind of discussions would actually encourage you to spend less on medications and thereby improve the quality of care. And availability. Some of the medicines may not be available in India. Some of the brands will not be available in one particular shop. So you have to discuss with the doctor whether I can take another brand medicine, but the same chemical composition. If that's fine, that should help you. So these are some important aspects. Then stigma. If you are taking some medications for mental health issues, there's a stigma to even purchase that. Going to the shop, asking that medicine, getting a prescription from some mental health hospital, all this carry a lot of challenges. The main thing is that mental health issues are as similar as physical health issues. If you have diabetes, hypertension, you don't hesitate to go and buy the medications for that. If you have major depression, or you have some psychosis, or you have memory issue, you should also consider that there should not be any hesitancy. These are not social taboos. These are for our mental health and physical health go hand in hand. There is no health without mental health. So there is no need for stigma, but this is something which has been documented in literature. You have to also be aware about the illness. Just because you have some psychological illness doesn't mean that you should just neglect it, but you should be aware about it, and awareness will actually help you. Social support system is quite important. Suppose who will be there in case somebody is in case of emergency? Is there a support plan? So these can actually be taught. The most important challenge is somebody who is institutionalized, somebody who is in a tertiary center or who is admitted in an old age home or a nursing palliative kind of facility. There the challenge is more. Especially if the consulting people, there are less qualified personnel, the medications and side effects and the interplay of all this will be significantly affected. So this is something which we have to be considerate of. So how do we kind of now address the problem? We know that we are dealing with a big problem. Now, how do we address that? The important aspect is consider the role of integrated care. Care is not just for physical health, but for mental health, and a holistic kind of integrated care is required. So multiple specialists has to work together through the available resources. So your primary physician would be the one person who is providing the integrated care. But the integrated care provision before is actually designed by the specialist also. So when you are actually going and meeting a neurologist or a psychiatrist or a cardiologist, you are integrating all their ideas. And then you are consulting the physician and telling that this is what they have all told me. And this is how I have to go ahead is what has been advised. So am I right in asking for that? So the physician should be the primary focus of care who would help in this kind of helping with the medications as well as the further care at community and home level. Then to provide accessible, affordable and high quality long-term comprehensive and dedicated care service is something which is an important concept which has to be realized. And there has to be a creating a new architecture for aging and to build a framework to create enabling environment for society of all. So it is something against ageism, which I'll come to in some time. Then the concept is to promote active and healthy aging. So aging well or healthy aging means it is developing systems as well as maintaining functionality which would enable well-being when you are older. So the functionality has to be preserved as much as possible. So coming to Mr. S, I think we have gone through all these aspects. We have understood some of the basic aspects. We have understood the interplay between diabetes and depression. We have understood the patient factors, illness factors, as well as the interplay between these, as well as the environmental factors. Now, coming to Mr. S, whom I had introduced to you before. S could be Sudhakaran, Syed, or Salahuddin, Sebastian, anybody, but known to us. So he is 76-year-old retired accounts officer. Identify his main problems. So he is having diabetes more than 15 years, hypertension more than 20 years. He is irregular with medicine. So being regular with medicine is one of the important aspects. If he were regular with medicine, he would not even have required his artery bypass graft. And his wife had passed away, following which he was significantly lonely. If this loneliness was addressed, there would have been lesser risk for him developing depression, which happened 2.5 months ago. And if he did not have developed depression, he would not have required antidepressants, which would have caused reduced sodium, and following which he had a fall and fracture of the hip and required surgery. So just treating the things at the base level would have helped him and prevented the entire snowballing into a bedbound state. So this is an important aspect, and the understanding and treatment will be, if such a person comes, is for comprehensive assessment and care. Prevention is very much important, but if prevention doesn't happen, we have to assess the person properly and provide care. Now coming to WHO has given some interventions for mental health issues. One is early diagnosis. Second is optimizing physical and mental health, improving functionality and well-being. Third is identifying and treating accompanying physical illness, which is what we were discussing. Fourth is detecting and managing challenging behavior. And fifth is providing information and long-term support to caregivers. Caregivers should never be neglected. The United Nations Decade for Healthy Aging is what is happening now, from 2021 to 2030. So here they looked into the important aspects and targets which has to be achieved. One is reduce ageism, that is, have a positive attitude towards aging and older people, rather than having a prejudice and judging them as incapable people. Don't think them as dependent population, but they are actually independent population and they are contributing people. Enabling age-friendly environment that strengthens the abilities of older people. So some people who have difficulty walking, if you give a good walking stick, if you give visual aids, if you give hearing aids, they'll perform better. Providing persons in their integrated care. So integrated care from primary care health service level would actually help in community delivery of care. And providing long-term care services for elderly requiring support, especially in rehabilitation. So these are some of the important aspects which United Nations has presented before us in the decade of healthy aging. So these are my references, and I thank the geriatric clinic team and my mentors, Professor P.T. Shivkumar, Dr. Preeti Sinha, Dr. Matthew Varghese at NIMHANS, and I also bring greetings from the Center for Brain Research in Indian Institute of Science, which is inside the IIC campus, and I thank you very much for this opportunity. Thank you.
Thank you, sir, for giving such an informative session for us. Now, I will request all the participants to ask your questions, and you can share your experience also.
Good evening to all. It is wonderful presentation, very well explained, the reasons, causes, and everything. Dr. Thomas wonderfully explained. It is one thing which can cause another, and if you don't take care of this, it can happen. Not only that, reasons, cause, and other factors you have explained very well. Thank you very much for your wonderful session.
Thank you, Doctor.
Thank you, sir.
The period of laboratory examinations, like blood test and other for seniors, may be explained, because once somebody says they once in 3 months or once in 6 months,
yes,
or a year, like that, according to the age.
yes.
And doctors also, whenever we go to physician, he will again get tested in all laboratory clinical tests. It is very, very hardship to the seniors.
Right.
Because we are having history of the case, as you said. What are all the ailments? What are all the tablets we are taking? We are furnishing all inputs to the doctor. Some doctors are seeing patients more number. They are also tired. They are not giving 5 minutes, 10 minutes to interact with the patients, other than family doctor. But this causes mental worries to the seniors, where they have no patience to meet doctors. These are all some problems regarding seniors. Thank you, Doctor.
Yes. That's a very important thing, sir, you are asking. If you don't have any illness, it is only recommended that you can have blood investigations, that is routine, once every year after you are 65. Otherwise, it is not required. But the most important thing, if you have diabetes and your sugars are not well controlled, it is always told that at least once in 2 months you have to check your HbA1c, which would be helpful. I think most of our people are also following that. And fasting sugar also, fasting as well as after food. So with this, and thyroid at least once in 3 months, if you have some history of thyroid. Otherwise, you can do it once in year, once annually. And if you're diabetic, if you're having BP, it is better recommended that at least once in 2 weeks you get your BP checked. And also, we should also not underestimate the role of food and other aspects. And now that COVID has also come, many a times it has so happened that now it is sometimes cold climate, people will develop cough, cold and all that. And that time also you go to a doctor, they will tell blood test. Okay. But we should all know, if it is a viral illness, you don't have diabetes, BP or anything, you can actually wait for a few days, at least for a week, till it subsides. So the general recommendation is what I was telling. However, it depends on case-to-case basis. And if there is a doctor near you, you should actually be kind of asking him questions. Many a time what happens is doctors are busy, they write something. We also go and get the prescription and tell, hello, take the prescription and come back. But doctors actually, I think, like people who talk to them, who ask them questions. Some people will tell, okay, I don't have time. You don't bother about the doctor's time. Many, I think it's out of respect for the doctor that he is seeing so many patients, let him see, I will not disturb him. But more than that, it is your health. And unless you are healthy, you are not able to contribute much to the society. So you can also engage him. Your question is very much valid. You should also ask the doctor, should I do this test again? Some people will go with little headache. Some doctors may write MRI scan or CT scan. So you can ask them, is there a need for that? If they tell there is no need, or if again headache comes, or it doesn't subside with medicine, then there is a kind of requirement for scans. So these things are tailored, and I think a meaningful discussion, every doctor will help. That's what I am thinking. And I think by everybody of us are well aware of that doctors work for you, and because of you only doctors exist. It is not that somebody is independent entity. So let us work in tandem. Okay.
Thanks for an excellent session, Doctor.
Thank you, sir. Thank you.
And very slowly and beautifully have explained the whole thing, the connection between diabetes and the mental illness. Doctor, you are also talking about the BP numbers. Can you just tell what is the best BP number? Because each one follows different numbers.
Yeah.
What will be the best number?
It depends also, sir. It is not that for me, if so why people give different numbers is there are some reason. The reason is, if you are a young adult male, less than 60 years of age, your cutoff for BP, you should be less than 135 by 85 millimeters of mercury, according to the joint JNC guidelines 8, which is the latest guidelines. If you are more than 60 years, your BP is 140/90, still it is considered normal. Okay. So as you age, little high BP on the higher side is not abnormal. But suppose your BP is very high. For example, it is consistently 140/90 plus. Morning, evening fluctuations also shows some things. More than that, if you get up, there are some symptoms like you will get headache, you will get some giddiness, you will get some vertigo means chakkar kind of feeling. Then you should treat it. Okay, so it is also based on the age, the clinical presentation, as well as the other criteria. If you are otherwise fit, you don't have any issue. Some people with chronic kidney problem, some people with chronic diabetes and other issues, thyroid problems, will have high BP. So their treatment of the BP is not just the solution. Treatment of the underlying kidney problem or thyroid is most important. And then the BP will come down. I think I know I am telling little scientific technical terms, but you don't worry. There is the truth is there is no particular number, but for practical purpose, any BP more than 140/90, you have to be careful. 140 is systolic and 90 at the diastolic level.
Thank you, Doctor. Doctor, see, only this. I have been regularly going to my, heart specialist.
Okay.
Thank God I don't have any issue as such. But normally what happens, he allows it to go up to say 150. He says nothing wrong because your age is, you are already more than 75. Therefore, don't bother about it.
Yes.
So that is okay, isn't it?
That is okay. That is okay. There is another reason I will tell you. There's something known as white-coat hypertension. Okay. So when at home, if I check your BP, it will be 140/90. But when you come to my hospital, I will check, it will be little 150/95 or 96.
Yeah, white coat. Yeah.
So, so that is because in a hospital, many of us will be anxious. We will be also having some fear of something will going to happen. Will I be diagnosed with BP? The main concept is, if I diagnose with BP, that means lifelong I have to take some medicine. Lifelong I have to be on some other treatment. This will be our fear. So our anxiety will increase and our BP will shoot up. Okay. So this is another challenge. So whenever we go to hospital, we should be as much as relaxed as possible. Nobody will diagnose you with high BP problem with only one reading. Minimum of 2 readings spread over at least 6 to 8 hours is usually done, or at least 2 readings in a week's time, which shows increased BP. Also, because many people are here, I would like to clarify that if you are diagnosed BP, having hypertension, doesn't mean that your entire life you have to take medicine. When the BP is normal, some consistently, things are fine, you can reduce the doctor's recommendation, you can reduce the medicine. And if still BP is fine, there is no other issue, there are many instances when we can actually stop medicine. So it is not that once you are diagnosed BP patient, your entire life you are BP patient. Somebody will have BP when he is having some 95, 96 kilos. When he does proper weight reduction exercise, when he becomes 80 or 75 kilos, his BP values will normal. Then he may not even require medication. So lifestyle changes, reduction of excess salt, added sugars, added processed foods, all that can actually help in reducing BP.
That's very reassuring, doctor. That's very reassuring. Thank you.
Thank you, sir.
Thank you very much, Doctor. I'm Leela Reddy.
Nice, madam.
I want to share my experience.
Please.
I lost my husband recently. He was diabetic, hypertensive, and obese, and he was a chain smoker.
Okay.
But he refused to go to the hospital. He never used to go to the hospital for regular checkup and all those things. And I have done MA in psychology, but even then, I did not know that his depression was related to this diabetes. He was very much depressed lately.
Okay.
So I'm really feeling very sad about it. I couldn't do anything. He was reluctant to go to the doctors. That's why.
I think I should actually credit you for understanding the illness. Okay. We cannot force anybody other than ourselves for treatment. So I think all of you are quite experienced with life also. You would understand that we can be friends with others, but we cannot influence others' decisions. Okay. So there has been a lot of side issues like other comorbidities he had, like he had obesity, he had maybe lung issues, and diabetes also uncontrolled, and some depressive element also. Okay. So I think all of this would have played a role. It is not just one cause. So you don't have to blame that one issue due to your lack of understanding caused it. No. It is good that you could identify this thing. And in such a forum, it is actually a way of motivating others to actually take care of themselves. And everybody has to be responsible for their health. If there is a circular in the paper or sometimes comes to us telling that you have to file income taxes by 31st of July or 31st of December, we all become responsible now. We do that. Similarly, more than that important is our health. Okay. So our health is in our hands and we should try for that. But we cannot blame others also. We cannot blame ourselves also. So I should admire your courage and appreciate your efforts, and you are a source of inspiration to others. You are also able to understand the cause for the illness, and just we were discussing, we were able to identify the various factors which played a role. And I'm sure it will not happen in your case. You will be more cautious about your health, isn't it?
Yes, thank you, doctor. The doctor used to come home and he used to tell him to go for tests and all. He refused to go, and he was taking medicines regularly. That was the only thing he used to do. But finally.
Okay, but let you. My only request and prayer is that you don't get depressed about that, madam.
Yes.
That will be my sincere prayer to God.
So let us be positive, madam. And in case of any issues and you feel that you need to talk, the NIMHANS team is always there. Please inform the coordinator, and any kind of services is required from the NIMHANS side, we can provide you with that.
Thank you very much, doctor.
That's very reassuring, doctor.
I have a question. Does any medications can causes mental illness, that example mood swings or like that?
Some medications do cause mood swings. Even in a general viral fever, if you get, you know that you will be a little irritable. And some of the medications, especially some of the BP medications, are known to cause some depressive kind of features. Some kind of TB medications which is given for tuberculosis can also cause some mood problems. Some antibiotics rarely. If you have an increased chance, if you are vulnerable to develop a mood problem and you take this kind of medicine, as a side effect, they can cause some. So it can happen, but it cannot be only due to medicines. Okay, if you have little vulnerability, okay, then the chance of developing the psychiatric problem is there. But the best thing is, if you stop the medicine, usually they should improve. So whenever you feel that a medicine is responsible, it is causing some side effect, please consult the doctor immediately and either stop the medicine or change to an alternate medicine.
Thomas, sir,
Yeah.
I would request you to please organize one workshop or session about vaccine for older adults, even if they are not sick. Which vaccines are available in India, and how and when they can be taken?
Okay, very good.
Yes, sir.
So I think this is a feedback you can also put into the Vayomanasa Sanjeevani Gmail ID. Okay,
sir.
So we can schedule it.
I would, because I'm undergoing one IFA course, education for health workers, and other countries are doing so much for making immunization, popular among adults, but we do not even hear exactly that there are vaccines available for other than COVID. COVID, it has taken the word with the storm. Yes. But other illnesses are there which can also be taken care with immunization.
I agree. I absolutely agree with you. And I think in the national policy for healthcare in elderly, there has been documented that primary healthcare facilities have to be strengthened. And this is something which policymakers can also look into, and collective kind of approach. Okay, if I take a workshop, it will be good for all of us only, but for the community at large, there should be
it is very important.
Yeah. So
because one of the specialized speaker was saying that we do not even focus about older adults. We only care for children immunization. So like vaccines for elders, nobody even hears about it.
Yes.
So NIMHANS can take the initial step.
Yeah. Yes, that is something which can be actually considered, definitely. But I would urge you to also put it across through the proper channel.
I would.
That it would reach the higher levels. And
I would do that.
The national policy can also be formulated because NIMHANS is an important caregiver.
I have written to vaccineindia.com.
Yes.
And I will write to NIMHANS Shivkumar sir also.
Very good. So we can definitely organize a workshop. No issues.
Sir, thank you very much.
Thank you. Thank you, madam.
Thank you, Asha ma'am. I have another question. Doctor, we have seen lots of people gone through different surgeries like bypass and major transplantations. So how does these surgeries affect the mental health of that people?
Okay. See, transplantation and psychological issue itself is a very big area. So if it is different, if it's a live donor, if it is different, if it is a family, a relative who is donating, it is different if you get it from a cadaver or a dead body. So it is a big challenging area, and it's a very big kind of thing. It is different. We have heard newspaper reports of transplant happening, liver transplant, mother is giving to child, the child is giving to mother, relatives giving to like that. There are a lot of challenges involved. Okay. First of all, it is not an easy thing to either accept transplant or give transplant. Both are difficult. So the psychological trauma is different across the thing. It also depends on the age also. Somebody who is in the 60s or 70s who may require renal transplant, he is getting dialysis maybe for 10 years or 15 years. He's still awaiting a transplant. His level of anxiety and depression will be different. So it is individual. You cannot generalize it, telling that transplant people have this issue or that issue. It is very highly individual specific. You have to understand the issue. And whatever, some people have failed transplant. Some people get transplant, but still they are not improved. Then there is another group of people who get illicit or black market kind of thing. Previously, you would have heard in papers that there are scams. People are getting kidneys removed and selling it in black and all that kind of thing. Now somebody sourcing kidney in that area, how does he think? So these are big challenges. I think at individual level, it has to be addressed, but collectively there are some national guidelines on transplant and some ethics you have to follow. That you have to be in the donor list, you have to be in the recipient list. Yeah. Anything else? I think somebody was speaking.
Thank you, sir. I have one last question.
Sure.
Can you throw some insights on hypochondriasis and how it affects the people, mental health?
So hypochondriasis is a condition wherein they have a feeling that they have some particular illness and they want to get rid of the illness by taking treatment from different sources. So that is hypochondriasis. It can even amount to the delusional level, wherein they feel they have unrealistic feeling of having one particular illness and taking treatment. They want to seek out treatment, and even with treatment, they don't feel fully benefited. So this can happen not just in elderly, it can happen in middle ages, usually seen in men and all. And the treatment is not just medicine, but also through psychological means by proper counseling and therapy, which should actually help them. Okay, so this is something which is very much important. They may feel that they have some abnormality, they are having some illness, and they cannot, it is not getting cured even after visiting multiple doctors. So that is one clue. And we have to tell them that you have to stick on with one doctor, and there's a psychological reason for this also. So you should not blame them. So I think I am clear now that we have to address these issues also.
Yes. So we are going to wind up here. If any participants more questions, you can ask now. Okay, we are coming to end.
Excuse me.
Yeah, okay, you can ask, sir.
You talk about integrated approach, but it is missing in this scenario because everybody goes for a specialist.
Yes.
One goes with his own specialization, and other he will say that you approach your doctor.
Yes.
How can we integrate that?
So that is, I share your concern very well, especially when you have a chest pain. Instead of going to a general physician, you will go to the cardiologist. Or now the situation is, even if you go to a general physician, he will direct you to a cardiologist, isn't it? Yeah. So the best thing in such a situation is you have to go to the specialist, because they will give some specialized and up-to-date kind of care. That is very important.
Yeah.
But after the main issue, the acute issue is settled. For example, if you develop a heart attack, you don't go to the psychiatrist. You go to the general physician or the cardiologist, who will see, who will give the medication, who will stabilize you. Once you are stable, usually the specialist will ask you to review only once in 3 months or 6 months. But the care should be provided ongoing through the family physician or the general physician. So that is one way of looking into integration at our level. Second thing is, sometimes people are also, some doctors are telling that other forms of alternate medicine may not be helpful. Okay, but there is a mix. You have to take the middle path. You don't have to absolutely go for it or against it. For example, some people get benefit with Ayurveda. Some people get benefit by external applications of Ayurveda. So in such a situation, you have to meet the qualified Ayurvedic doctor who will give some inputs. You also should discuss this with the cardiologist, that if there is some internal medicine which has to be taken internally, you discuss with your specialist. And once you clear all these issues, make a consolidated prescription, get it ratified by your general physician, and follow that order for regularly. That would be practically the easiest thing to do at our setup. Otherwise, one doctor, one treatment is not going to kind of help with the other systems. So unfortunately, our system is like that. We have a lot of specialists and people run to the specialist. But my opinion is, if we go to the specialist, get their inputs, but integrate it finally with the family medicine. That is what the family physician is for. You will integrate, you will tell, okay, you need to follow up with your cardiologist after 6 months or after 3 months. Follow that. This is what I would say, along with a healthy integration of all the dietary practices, Ayurveda, yoga, all should actually help. So integration is now possible at our level rather than at the system level by the government. I hope it will come up maybe in future, but at this point of time, it is mainly our initiative which should help us.
Yes, it is a great initiative. Thank you. Thank you, sir.
Thank you very much.
Coordination between specialists in medical college hospitals, either government or private, how to improve. A patient is admitted, how to get involved, because various diseases are diagnosed, to be diagnosed. This is, I think, an issue.
Yeah, it's a big issue. I think if that were there, we will not have even asked this question, isn't it? The coordination between big specialists in different big wings of the same hospital is difficult. But I think we are going in the right direction. Now, previously it was like only cardiac hospital. There was something known as cardiac hospital, kidney hospital, lung hospital, like that. I think now that is coming down compared to before. People are, even in big hospitals, they require psychiatrists, they require neurologists. So many people will see the patient. And in ICU, that is exactly what happens. I think COVID has given an idea, because COVID has attacked every system, not just the lungs, in the brain, in the renal system. It has worsened diabetes, it has caused psychiatric problem. So now everybody is geared up. So actually, we should utilize the coordination, and coordination between doctors should be at not at individual level. It should be also at the higher level, so that care is not compromised. It is for the patient's care is the first priority. Then subsequently, if somebody is having heart attack, he is also having some weakness of one side of the body. It is important to treat the heart attack first. So we should have a clear pattern. I think hospitals have this system in place, but definitely, sir, like you pointed out, a national policy on this regard also would be very welcome. Instead of creating very specialized hospitals, if you have a general hospital which will take all this into account and look into the patient choice also. When he is stable, he would have opted for some other options of treatment. So give that opportunity. I think that will happen, but not immediately, at least in the long run.
Money is not a problem. Every doctor who is visiting the patient, they are charging,
Yes.
but not collectively. How to cure the patient, particularly seniors? They are already in depression mood.
Yeah. First thing I think is now the concept is health for all. Okay, charging and money should not be the first priority now. And I think now there are a lot of schemes, including this Ayushman Bharat. At least in Karnataka, I am aware that if you have VPL card and you have this Ayushman Bharat Arogya Karnataka scheme, which gives 5 lakh of treatment per year. Okay, what I am thinking is this is for patients with below poverty line.
Tamil Nadu is also having insurance.
Yes.
Insurance. And private insurance, like that. Even senior citizens are having chief minister's insurance policy.
I agree. I fully agree. So we have to reach the NHS model, which is in UK. Even though we tell you we are not very happy with UK people, but The thing is, in UK, the NHS model is there, which gives care for everybody, irrespective of their paisa. If they are BPL, APL, anybody, everybody is insured. Similar one process if happens in India, we will initially think this is very resource thing and all that, so much money will be wasted. But if your people are healthy, if citizens are healthy, then these resources will be useful. Rather than telling that this will consume crores, if everybody is given equal treatment, I think that is the reason even politicians are flying abroad for treatment. Even though they claim that the best treatment is available in India, why should they go abroad? So I think quality of care, if uniform and given to everybody all across India through a proper centralized scheme, looking at all the benefits and other disadvantages, that should be the best thing possible. Maybe it would happen in future. Maybe we can all work as a holistic kind of thing. It should happen.
Thank you, doctor. Thank you, doctor.
Thank you, sir.
So we are running out of time, so we are winding up here. Thank you, sir, for clarifying the interplay of medical comorbidities with mental health and giving us insight on diabetes and depression and the environmental factors are influencing it. Thank you, sir. Gina, on to you.
Thank you. Thank you once again. I would like to thank Dr. Thomas sir for getting our taking our invitation to and have this wonderful session. And I would like to thank Lima also for moderating for today's session. With that, I would like to thank all the Zoom and YouTube participants who have joined. With that, finally, I would like to thank all our partners, Government of Karnataka, Karnataka State Legal Service Authority, Bangalore Apartment Federation, Happy 60 Plus, Samadhana Counseling Center, Indian Psychiatric Society, Karnataka, Icon Life Science, REC Foundation, and NSC Foundation. With that, I would like to wish all a wonderful evening. Thank you.